afternoon, everybody. So I've been extremely fortunate to be on the leadership committee of OBS Cymru, which is a multi-professional all-Wales quality improvement project, which has improved the care that we deliver all women in Wales when they bleed during childbirth across all maternity settings, and started in about 2015. What I'm going to do over the next 20-25 minutes really is tell you the story of this project, how it started, how we developed a local project and scaled up on a national level, and really some of the lessons that we've learned along the way, and that might be transferable to all of us as we take on projects in the future. Okay, so where did OBS Cymru start? So the research that founded this project started actually over 10 years ago now in Cardiff, and it started with a collaboration between anaesthesia, obstetrics, haematology, midwifery, and also Cardiff University and Health and Care Research Wales. We were really interested in understanding more about clotting during bleeding, during childbirth, and how we might improve the systems that we were using to manage these women. Our research started predominantly with observational studies. And as you can see from our observational data regarding the blood transfusions that we were providing to our women in Cardiff and UHW, things really didn't change very much whilst we were looking to really understand what was going on in an observational setting. We then started a major interventional study between 2013 and 2015. And this was really led by Professors Collins and Collis, who unfortunately aren't here today, but supported by the multi-professional team. And what we found whilst we started doing this interventional project was that there was real change occurring on our delivery suite in the way that we were managing our women in terms of the red cells that we were giving our women and the FFP that we were transfusing. What we were doing was bringing a bedside test of coagulation called a ROTEM into our clinical practice and using this to inform how we would then transfuse and deliver care to our women. Giving women who had a coagulopathy blood products early in their bleeding, whilst not giving blood products, and applying prudent principles to the women who had normal coagulation, which was the majority. But we were doing more than just putting a bedside test into clinical care. We were also routinely risk assessing our women in order to identify whether or not they were appropriate to go into the research studies. And then we started doing something completely different. Up until about 2012, across the UK, whenever a woman bled when they were having their child, we would estimate their blood loss. This was completely impossible in the context of a clinical trial, because if you're going to recruit women and give them interventions based on a blood loss, you have to have a defined entry criteria, so we had to start measuring blood loss. And this was a real game changer in the way we were delivering our care, and driven by our midwives, our healthcare support workers, and our theatre nurses who would be doing the measurement. We then escalated through our multidisciplinary teams based on either the measured blood loss or clinical concern. So the measured blood loss really was the critical intervention point in the project, then enabling the multidisciplinary team to get at the bedside at a litres blood loss so we could then perform appropriate interventions. In the majority, giving supportive treatments, medical and pharmacological means of treating the bleeding. In the minority, giving appropriate targeted hemostatic treatment, using the bedside test of clotting to tell us which group we should be treating. We realised that it was this entire approach that was starting to change the way we were looking after our women and actually translating into changes and outcome in terms of our major bleeds and how we were transfusing our women. So how did we take this germ of an idea that had started in Cardiff and then scale it up across Wales, across all of our 12 obstetric-led units, multiple maternity settings across Wales with very different contexts in terms of Bronglais, who deliver 500 women a year, up to Cardiff, who deliver 6,000. and a total of 30,000 births per year. So we started by talking about these ideas and the research and what we were finding in Cardiff in all of the multi-professional fora across Wales, be that anaesthetic, midwifery and obstetric. And we had a huge enthusiasm for change and an all-Wales approach. And then we started identifying the stakeholders that would need to be engaged in this and getting their collaboration and buy-in from the idea of the project right from the start. This was really important. We then started looking for funding. The funding stream that we successfully applied for was efficiency through technology. This funding stream is no longer available within Wales, and so what I've put up here is the 3 funding streams that you can now currently apply to: Accelerate, Invest to Save, and Innovate to Save. I was still a locum consultant when I applied for this. We put in an application within 3 days and didn't think we had a hope of getting any funding, and found out 8 weeks later that we'd got everything we'd asked for. And actually now we had to turn an idea into a project. This was a bit of a shock to all of us because we hadn't really ever had any experience of scaling up a project of this size, and had to work extremely hard over the next 6 to 8 weeks to identify the relevant people in finance within Cardiff and Vale who would actually support us in taking this from a local project to a scale-up project. And I have to thank Richard Hurton, because I knocked on a lot of doors before I finally found someone within Cardiff and Vale who was happy to actually take on a project that would be far outside their scope of normal practice and enable us to actually use our funding across Wales. We then needed to think about who was going to help us deliver this project. In order to deliver change on a maternity unit, and I imagine this is very similar across all of the different areas that we work in medicine, you can't just embed a change and expect it to happen. You need to engage with the professionals working on the shop floor. And for us, if you want to make a change in a maternity unit, you need to engage your midwives. And so very early on, we identified that in the leadership team within this project, we needed to have a multi-professional representation. Unfortunately, in our funding, we hadn't actually asked for any staff costs whatsoever. And so part of the very early challenges within the project was identifying 1,000 Lives Improvement Wales and the Maternity Network Wales, speaking to them and understanding how we might be able to fund key leadership posts, not just in the medical teams that would be leading the project, but in the midwifery teams that would be leading the project. And it was really important to have a Band 8, so a senior leadership role within midwifery that would enable this project to be taken forward. We also realised that as consultants in haematology, obstetrics and anaesthesia, we did not have enough SPA time to deliver a project of this size. And so then looked further afield to what opportunities we might be able to deliver the trainees that could work with us. It was at the same time that I saw an advert come out for the Welsh Clinical Leadership Fellow posts. And so working in collaboration with my clinical director and the Betsy Cadwallader anaesthetic clinical director, we put together some Welsh clinical leadership applications and actually have got through a total of 6 Welsh Clinical Leadership Fellows over the course of the project. These are doctors in training who take a year out of training to work on a project, OBS Cymru for us, but also to gain additional experience in leadership and management. And they have been absolutely fantastic. We've had predominantly anaesthetists and obstetricians, but we would have taken doctors from any speciality. They have given hugely in terms of their time for the project and their knowledge as they've become better leaders and managers during the course that they've been attending. But they've also given our project an entirely different audience because as part of their leadership and management training, they go to Welsh Government, they meet Chris Jones, they meet the ministers. And the first topic of conversation is, right, tell me about your project. And so suddenly, from being a small acorn of a project, it started to grow exponentially. Sorry, one more thing about teams. The other thing that we recognised early when we were developing our teams was that if you want to affect change across Wales, you cannot understand the context of all of the different units across Wales working in a single site. And so once we developed our national team, it was then extremely important that we identified local leadership teams that were multidisciplinary again, consisting of an obstetrician, an anaesthetist, a midwife and a haematologist in each obstetric unit that would then lead, drive and affect change on a local level, supported by the national team, but affecting local change. And particularly within the funding, we managed to give our midwifery colleagues time to do that. Again, as doctors, we get SPA time. We're very lucky to have that, and we need to use it wisely. But a lot of our healthcare professional colleagues do not have any time to deliver quality improvement. And if you don't give anyone any time to do it, they're trying to squish it into their normal clinical commitments, and the project won't get off the ground. We only gave our local leadership midwives 3 hours a week, but that meant that they were so engaged in the project. And as I go through some of the successes that we've had, you'll see that it was really the midwives that led the early successes. Okay, so we had some money, we had some people, and we had some ideas. But then what I realized very early on was that I'm experienced in running an anaesthetic list and working with my surgical colleagues in a team. I have no idea how to run a major quality improvement project across 12 sites. And I would really urge anyone who's starting to consider doing anything like this that we actually need to have project management training. Now, this may only require a day, it may mean longer than that, but in order to really be able to develop the governance in your project, the structures within your project, understand routes of communication, you actually need to have some specific training on this. Otherwise, you can really feel quite lost at the start. And this is something that we did as a leadership team once we'd started to evolve the project. And following on from that, that then gave us our structure. So we had a national board, which had, as I said, multi-professional representation, but also, importantly, a patient sitting on that board, myself as project manager, and then our team managers, which was, again, multidisciplinary, who would then support our local champion teams, which were multidisciplinary. So then how did we actually then put this idea into practice across all of our 12 delivery suites? So we used recognised quality improvement methodology and worked closely with 1,000 lives to ensure that our leadership midwives had appropriate training in quality improvement methodology as we went through the project. And we used PDSA cycles. So we started with the planning in November 2015, launched the project 2016, and then finished it this year. And then really the first planning phase was around establishing those teams. As we were planning, though, we realised that actually, for me, the quality improvement methodology needed more. I needed to understand more about how this project was going to run. And so we actually looked further afield as well. And within Cardiff University, there is a group called Decipher who actually have written the entire manual on how to understand how a complex intervention actually gets put into as a project. And so we actually went and visited these guys to really understand how we were going to put this project in and how we were going to enable it to be flexible and work for all of our sites that were so different in terms of logistics, staffing, location, and how we were going to have a national way of doing things, but could then be flexible to the needs of the unit. So we spent quite a lot of time understanding the context of each unit, so how it was set up, what were its challenges, how did the local team need to understand them, and how could we as a national team support them? And then we were very clear about the interventions that we were going to put into all of our sites in terms of measuring all blood loss, using the standardised paperwork, and putting in the piece of technology into all of our 12 sites. And then we thought about how we were going to roll that out and how we were going to ensure that the rollout was standardised, reaching every woman at every birth, and then specifically giving tailored treatment to the women that were bleeding. And then how was it actually working? And for me, this was really quite a new way of looking at things and collecting sufficient qualitative data, so responses and information from from the staff on the shop floor, from the theatre nurses, from the MCAs, from the midwives, from the obstetricians, the anaesthetists and the haematologists, about how this was actually working. What we thought we put into practice, was it actually being used the way we thought it was going to be? And we did a lot of qualitative surveys and also patient surveys to really understand what was going on. And then eventually we started thinking about our outcome measures. So what did we do? So we put the entire approach into all of our 12 units in a stepwise manner during 2017. And we embedded it into all of the routine cascade training opportunities, and also started thinking about how we could use the networks that were already there and then build more networks. And this was really important, particularly for our midwifery colleagues, in linking them up between the hospitals. So when they came across a barrier to change, for example, a lack of weighing scales, they all had the same problem. So then we were able to then collect that data on a national basis, and from a national strategic viewpoint, then work with our stakeholders to remove that barrier almost within a week, so that then they could get on with then talking to the staff that were delivering measured blood loss on the shop floor and starting to enable them to actually change their practice. We then thought about how we were going to study, and as I've already alluded to, we thought about this pretty hard and focused initially mainly on our process measures, how we could describe them, and then how we could feed back data to our units real time so they knew how things were changing. And data is absolutely key. It's extremely difficult to collect good quality data. And for us in Wales, it was very challenging because all of our maternity units have different maternity databases. So there was no one unified system. We didn't know what our PPH rate was across Wales. It's actually quite difficult to even know how many women have given birth in Wales. So it was quite challenging at the start. And we used a number of different methods. We had a national database, so we were collecting national data for some of our process, but all of our outcome measures. And then we did biannual audits to really, really understand what was going on the shop floor for all of our women. This is an example of one of those, in which we looked at the percentage of mothers, all mothers, this is now, who had their blood loss measured. And as you can see, from 2016, just at the project launch, we've gone from under 40 to now where about 90% of our women have all of their blood loss measured. This was because of our leadership midwives. But without this step, the rest of the technology, the multidisciplinary team, the rest of the intervention wouldn't have been able to happen, because you had to measure the blood loss to be able to then escalate. And actually, this has hugely empowered our midwifery colleagues to advocate for the woman, to call when they need help, but also sometimes when they measure the blood loss, it's much less than they anticipate, and then keep clinical care within midwifery. But critically, as I've said, what we needed to do was analyse this data on a national level, but then give it back to our local teams so they could then use it to drive their local change. This is an example of the national data set, but what we would do is give each of our local teams their local data against the national ranges so they could look at and see where they were performing well against the nation and where they needed to do better. We also started sharing our outcome data, which we hadn't been doing before. So this is a funnel plot showing the number of maternities along the bottom, with UHW being the largest unit on the right and bronchiolitis being the smallest on the left, and everyone in between, and the really large postpartum hemorrhages of over 2.5 litres at the beginning of the project. We hadn't been sharing our data like this before, and it took us a while of discussion and support between all of our networks and our units before we started putting our names to our points, although some of them were fairly obvious from the beginning. But what we could see were there were some huge outliers there. And the real push on the project then was to see how could we reduce that variation and improve practice across Wales. So then we continued to cycle around our PDSA cycles, sharing learning, having annual meetings to really bring the entire multidisciplinary team from every unit together to talk about some of the challenges and the barriers that they'd come across, and also to share how they were overcoming them so then we could accelerate the speed of change across Wales, sharing our data and revising the tools and training. And we did this multiple times as the project developed based on the feedback we were getting from the units on the shop floor to make the paperwork, the protocols as user-friendly as possible so they would become normal practice. having flexibility within your project is really important, and using that qualitative data and the staff feedback to actually then change what you're delivering enabled us then to change to the local context, but also the national project steer. And the other thing that we were able to do as the project progressed was integrate into other initiatives as well, and particularly the prompt and multidisciplinary team training approach came out across Wales at the same time as we were rolling out our project. And so immediately we then embedded the OBS Cymru PPH station into that initiative. Critically, we were always listening to our patients within the research, but also within the project via national steer, and then also collecting patient stories and patient voices as we were going through the project, and then embedding their feedback into the training. It's really important to keep motivating and keep enthusiasm up for the leaders on the shop floor who are trying to break down the barriers to change and trying to effect change. And we really tried to do this as much as possible by enabling them to have certificates and understanding how the project was progressing, and giving them CPD and giving them back thank yous from the national team. This is one of the awards that the project has won, that we won quite early on, and we invited all of our team to come and celebrate that. And these are some of the other celebrations that we have around our project. So as I've shown you already, this is our funnel plot for the beginning of the project. And then here we have in 2018, the outliers have all started to come down towards our mean, which has dropped now. We're the only principality within the UK that's seen a fall in its major PPH rate. Scotland have seen quite a dramatic increase over the last few years. We've dropped that by 24%, which equates to 30 mothers a year in Wales. We've also reduced our red cell usage across Wales now. So this is a SPC chart showing the all Wales weekly red cell transfusion, and we've broken it down into 6 monthly portions, and what you can see is that there's been a stepwise reduction in the average number of red cells transfused during the project. That's again a 25% reduction, which equates to a saving of 450 units per year in Wales, and the changes are still ongoing. Throughout the project, we've also thought about how we were going to turn a project into normal practice and how we would make it sustainable. We are sustainable because we are now normal practice, and I can now say that because we finished the project in April. But there were a number of key areas that we realised we had to work on very hard to achieve that. And anybody who's thinking about a project, be it big or small, I would really recommend that you have a look at this this publication, which unfortunately hasn't come out, but it will be on my slides and I can share it with anyone who wants to see it. It's from NHS Improvement, and it's their sustainability guide, and it splits your sustainability up into your staff, process and organisational domains, and then really gives you a flavour for then where you need to look at in your project in its last year to achieve sustainability. And for us, that was the data, it was funding the technology, and it was looking at how we were going to continue to give our staff time to deliver change. Okay, so in summary, I've seen a lot of Wales over the last 4 years in all conditions, and it's an amazing place to work. And the multi-professional teams that we work with are absolutely committed to improving the care that we deliver our patients. And working with them means that you can deliver projects on this scale, actually at quite a pace. I would suggest that when you're working with your multi-professional teams, you need to make sure that we're giving time for particularly the non-doctors within those teams to be able to deliver and work on their quality improvement, and that we look at how we're working within the networks that are there and building networks. Think about the data you're collecting and making sure that it's flexible, and then working on enthusiasm and buy-in across all of your units. And finally, start thinking about the end of your project at the beginning. Thank you.